Good morning, everybody. Today, my discussion topic is headache, the most common pain problem that the patient may present to you. In considering the diagnosis of headache, it is helpful to know the pain-sensitive structures of the head and their innervation. Blood vessels, dural, arachnoid membranes, skin and muscles, aponeurosis, periosteum, upper cervical spinal roots, joints, eyes and ears, paranasal sinuses, and terminates are sensitive to pain. Most, if not all, of the brain is not a pain-sensitive structure. The upper three cervical spinal roots, with contributions from the 9th and 10th cranial nerves, innervate the most of the ipsilateral posterior fossa. Contents of the anterior and middle fossa are innervated by the ipsilateral trigeminal nerve. Stimulation of the C1 root has been reported from the ipsilateral frontal and eye pain. This is a picture of the brain and the cranial nerves. Aponeurosis, anterior fossa, skin, periosteum, dural membrane, arachnoid membrane, blood vessels, posterior fossa, muscles, spinal roots, cranial nerve 10, cranial nerve 9, trigeminal nerve, middle fossa and cranial nerve. Headaches that may require urgent and specific treatment. The clinician first should consider the possibility that headache may be a result of a cause that requires urgent treatment. Often, careful history taking provides the most important diagnostic clues. Most patients with headache have no relevant signs and on elementary physical examination. However, sometimes even subtle anisocoria, strabismus, papilledema, a retinal or subhyaloid hemorrhage, a tender firm temporal artery or subhyaloid hemorrhage, a tender firm temporal artery and intracranial bruit, a scalp infection, hemiparesis, and other signs may help secure a diagnosis requiring urgent diagnosis and treatment. Blood vessels, dural and arachnoid membranes, skin, muscle, aponeurosis, peritonitis, and periosteum, spinal roots, joints, eyes, ears, paranasal sinuses and terminates are sensitive to pain and brain. D. For the most part is not. Brain is for the most part is not. Most of the posterior fossa on one side is innervated by the ipsilateral upper three cervical roots with contributions from the 9th and 10th cranial nerves. Contents of the anterior and middle fossa are innervated by the ipsilateral trigeminal nerve. Stimulation of the first cervical spinal root has been reported to cause ipsilateral frontal and eye pain. The abrupt onset of severe headache, often accompanied by photophobia, nausea and vomiting, is highly suggestive of subarachnoid hemorrhage and a hemorrhage from a ruptured intracranial aneurysm or arteriovenous malformations. Neurologic signs may include rigidity, neck rigidity, decreased level of consciousness, retinal or subhyaloid hemorrhage, third or sixth cranial nerve dysfunction, papilledema, leg weakness, or focal signs from the ischemia secondary to spasm of cerebral arteries. Seizures may occur. Diagnosis of non-traumatic subarachnoid hemorrhage is even more likely if the pain began during the straining, when a patient presentation suggests a non-traumatic subarachnoid hemorrhage, when immediate workup and treatment are mandatory. A computed tomogram CT should be obtained. If, despite a high index of suspicion, the CT does not document evidence of subarachnoid blood, then, assuming that there is no strong contraindication, a lumbar puncture should be done. If the CT or LP documents evidence of subarachnoid blood, then a magnetic resonance arteriogram, that is MRA, of the head should be obtained promptly. If no aneurysm or arteriovenous malformation is seen, but the history and signs strongly suggest the subarachnoid hemorrhage, then conventional cerebral arteriography should be considered. If an intracerebral aneurysm or AVM is found, then immediate neurosurgery, and when indicated, an interventional neuroradiology consultation should be obtained. Okay, this for today. The next part will be coming with the next video. Thank you.